in advance of today's meeting, and we'll be responding to that query as part of our updates and the quality reports from our Chief Medical Officer, and we'll also be able to respond in writing. We've had another query from a provider of services, and we'll be responding to that one in writing as well. We have 9 members of the public signed up to attend today's meeting, and I hope that there may be several more, particularly welcome to our system partners who might be joining today, and our Mirror Board members who also received a standing invitation. Thank you very much, everybody. Let's move to the agenda then. Our first item is the conflicts of interest register and any declarations of interest which may be new or relevant to today's meeting. I note also that we're in the process of updating new members' information. So colleagues on the board, any new declarations or anything relevant today? Thank you. You'll find in our papers the minutes of our last meeting in public held on the 19th of November and the matters arising. Are there any comments or questions on those? May I take those as an accurate copy of our meeting? Thank you very much, everybody. Well, as we start this new year, I'm going to hand over to our Chief Executive, Fiona Edwards, for her report. Thank you, Fiona.
Hello, everyone. Happy New Year to everyone. Few things from me. Obviously, it's been an incredibly busy time across the Frimley system with Christmas, New Year, winter pressures. Everyone is aware of the scale of COVID, flu, RSV across our system, manifesting with high attendance in primary care and also in our hospitals. However, that said, with those pressures, people have done a phenomenal amount of work, done really well, and have been able to continue a path of improvement in terms of our urgent and emergency care performance, of seeing people within 4 hours, and also in our waiting list, reducing our long waiters. Now, we've had publication of the elective reform plan last week, and we're working through that with partners to ensure that we can hit the requirement of improvement in the 18-week target for seeing people and treating people, and seeing an improvement year on year to meet the government's commitment within its term. And people are working really well in that space to get our plans together and to build on the improvements we've already been making. Our financial performance for the year, we'll have the performance in detail from Rich, is also showing improvement as well as we come into the last quarter. So we maintain really our position as being a high performing system through teamwork, partnership work, and strong relationships together. And just on that point of people, I just want to publicly acknowledge the honour to Julian Ems, Chief Executive of Berkshire Healthcare, receiving an OBE in the New Year's Honours List. Really well deserved as a leader of a very high performing organisation, but also working in partnership with us. He's been the sponsor for the temp agency collaborative across the South East region, which has managed to improve practice across all acute hospital providers in the southeast, and also save money and ensure better deployment of staff. So as well as the huge improvements and his personal commitment, along with members of this board, including Alex, to being an anti-racist organisation. It's lovely to see a leader of his calibre honoured in that way, who supports some of our priorities, values and ethos, as well as the system. And the other thing that we're delighted about is the confirmation of Frimley Park in the new hospital programme. You know, the review that was the results of the review that was announced yesterday. We didn't expect it to affect us, but it's good to see it confirmed in terms of priority and timescale. That said, it does emphasise that as part of our planning work and our strategic review work, but also our public engagement work, that to continue to strengthen and reform and transform the system, we have an absolute imperative to create a proactive model of care across our whole system, using our digital capability, not least in terms of being able to segment and target our attentions to members of our population that most need, but also to create the shift to a much greater focus in primary care, in neighbourhood teams, and out of hospital care, in order to be able to build a new hospital at the right size. So we've got everything going in the Frimley system. We've got the neighbourhood hub that we signed, that has had planning consent and is starting in Bracknell Forest as another example. So it is great what we do and what we can achieve together, but it is really hard work for people, and the pressures are very high as we face the anxiety of trying to develop a plan that will be a balanced plan for next year, and also take into account what we've got to achieve over the next 5 years as we develop our models, change our delivery in order to build a spanking new hospital that is fit for purpose in a whole system context, to replace Frimley Park. And the last bit from me is our wider, I've touched on Frimley's broader leadership role across the southeast, as I've mentioned, the hosting that we give to the temporary and agency collaborative. But also we are the lead integrated care board for all things delegated commissioning, really. So we host the hub for the southeast for pharmacy, optometry and dentistry, and we are working with partners now to formalise full delegation over the course of the next 6 months of what's called specialised commissioning. Our mirror board has had a look at where we've got to with that. Our board's just taken a look at it. It's highly complicated because it's unravelling arrangements that are held nationally and regionally, but actually it's also got to be really clear that we hold some stuff at scale across region, whilst we enable ICBs to really have more control over resources local to their population, so they can really have a population health-led approach to strategic commissioning as we move into the next year, and we get ready for really delivering the new government's, it's not that new now, but the new government's imperatives, but also the 10-year plan, which we'll hear a little bit about our public engagement work on shortly. And that's it from me, Priya.
Thank you very much, Fiona. Let me open it up to comments and questions before we move to that coming year plan. I think we are going to pick up on all of those issues as part of today's discussion, so let's move forward. Thank you. Our next section is our outstanding use of resources, and I'm going to hand over to Sam Burrows, our Chief Transformation Digital and Delivery Officer, to look at the 25-26 forward plan. Thank you, Sam.
Thank you very much, Priya, and good morning to everyone who's joined the board today. So I'm going to just give you a brief outline of where we currently are with our thinking around 25-26, around how that feeds into a more medium to long-term planning frame, thinking about the next 5 and 10-year period, and the supporting work that has been delivered to date, which has helped us to shape our thinking and approach to those activities. So firstly, the board should note that NHS England has not yet issued planning guidance or confirmed financial allocations for 25-26 to the NHS. Now, this clearly is material because those are critical pieces of information which confirm both the national asks and requirements from the NHS for the year ahead, but also the financial resources which will be made available to local systems such as Frimley to ensure it can plan for how it will meet those asks within the funding which has been made available. Nonetheless, we are expecting both of those pieces of information imminently, hopefully this week, and we'll be updating the plans that we've already been working on as is appropriate and required. In reality, planning is a constant process rather than an episodic one. And we have been preparing for the year ahead for some time. And as you'll see from your papers, which include a summary output of our board seminar in December, throughout the autumn period, we were already working towards what would our plan for 25-26 look like, including our local priorities, our best information available around national priorities, which have continued to emerge over the last few weeks, and to put ourselves in the best possible position for planning as a partnership going into 25-26. The board should note that this is the first planning window. It's the first full year since Lord Darcy's investigation into the NHS, which was published back in October of 2024. And whilst we're expecting a national 10-year plan for the NHS to be published in the summer, most likely May or June, for us, this is an opportunity as we go into the year ahead to really take stock of what Lord Darcy set out in his investigative report, and an opportunity for us to accelerate our own local plans with regards to this. So the three key themes of Darcy: to shift from analog to digital, to move from hospital to neighbourhood, and from sickness to prevention, essentially are a core part of what Frimley has been trying to do for some years now. And the first Frimley ICS strategy, creating healthier communities, which was published in 2019 and subsequently refreshed in 2023, continue to be our foundations for how this work will be delivered. And those three Darcy themes will form the bedrock of our transformation programme for the year ahead, and we're looking to really deliver this at pace. Not only will that work support the transformation of services and improved outcomes and experience for our whole population, as Fiona referenced in her chief executive's report, these will also enable the delivery of the new hospital for Frimley Park, which was confirmed by the Secretary of State yesterday, and we are all delighted that that has now been confirmed. So that transformation programme and the opportunity to deliver more quickly than other parts of the country, and to really accelerate that work into 25-26 will form a core part of our plans. Alongside this, however, we should note that there are obvious needs for improvements to the here and now of services that are provided, and the outcomes and experience which our patients receive today. And we're fully expecting to commit to a plan for the year ahead, which has improved waiting times for patients in our urgent and emergency care sector, has lower waiting times for patients waiting for planned procedures, including an improvement in the proportion of our population who receive access to planned care procedures within 18 weeks of a referral being made, and also ongoing commitment to delivering all of this within the financial allocation which has been made available to us from NHS England. These will all be enabled by some really significant developments, which are also going to happen over the course of 25-26 and have been years in the planning themselves, such as, for example, the opening of the Community Diagnostic Centre in Slough, which will be a key enabler to us ensuring that patients who require investigations, potential cancer pathway treatments, or diagnostics as a part of their elective care journey have access to that care much more quickly than they do today. And this, I think, underlines what I said earlier, which is that this is a rolling multi-year approach to planning rather than something which we stand up only at this time of year. Now, as you can see from the slide that's on the screen today and from the papers that were issued in advance of this meeting, we discussed much of this as a board when we came together in Windsor in seminar mode in December. Hopefully, colleagues had the chance to review the outputs of this in their papers. And I would just really like to reiterate the broad level of support from the board to the approach that I've shared with colleagues today. What's most heartening, I think, to me is that our board is really representative of our broader health and care sector. We have members of the board with expertise from local government, from primary care, from mental health and community services, and from acute secondary care as well. And I think it's fair to say that as a board collectively, there was a really strong commitment to us accelerating this work and delivering the ask as I have set out this morning. Finally, I will just touch on the engagement work which has been undertaken to date, because crucial and central to all of these plans, whether for the year ahead or over that 5 or 10-year period, is what we hear from our population and from our partners for what they need from the NHS to ensure that there is improvement in what our people receive in terms of health and care services. Now, in your papers, you'll see in paper 5.1.2 a clear summary of the work which has been undertaken to date since we launched the Reconnect, Reset and Rebuild engagement exercise at the end of the autumn. Now, phase one of that work is drawing to a close. More than 100 partners have been met with, spoken to, heard from during that period, and more than 44 organisations in the Frimley geography, including those in the voluntary and charitable and social enterprise sectors, have shared their thoughts with us as well. We've undertaken multiple sessions listening to the views of our partners and local people, and there are a number of upcoming stakeholder sessions in the diary as well, some of which are confirmed in this paper and others which have been arranged since this paper was published. What's really important, I think, for the board to understand from this work is that we will be able to pull together a really strong narrative which sets out a summary position of what's important to local people and what our partner organisations, no matter how big or small they may be in the health and care partnership, to ensuring that we're meeting the aspirations of local people. And the output of that work will absolutely inform not just our plans for 25-26, but also our longer term transformational programme as well. Chair, I'll pause there if that's okay, because I know I've rattled through a fair piece of information, but I'm really happy to take any questions from colleagues on the board, should there be any. Thank you.
Thank you very much, Sam. And I can open up now for comments and questions from the board. I'll just look to see Sajid come in, please.
Sajid, we can't hear you. You're on mute, I'm afraid.
Sorry. Sam, thanks for the update on the criteria that you mentioned about metrics that matter, and kind of coupling that with the work that the team is doing locally. How are you getting kind of community input and patient input into those metrics? Obviously we have the national ones, but I'm more interested in kind of the ones that impact us more locally and kind of more longer term strategic ones that we are pursuing.
Thanks, Sajid. It's a really helpful question. And we should note that as a local NHS, we collect a huge amount of data in terms of the work that is done locally, and the services which our residents access on a regular basis. And how we use that data analytically is really important to inform not just us being able to evaluate how we're doing, but also the work that we need to do to drive that improvement overall. You're absolutely right to say we report an awful lot nationally because we are required to do so, and that reporting is really important, some of which you'll see later on in the meeting. But there is another layer that sits beneath that locally around triangulating what we hear through engagement with the population around what's important to them and what they expect to see from us as their local provider of care, and the quantitative analytical data that we have that tells us whether we're making progress in being able to meet those asks and requirements of local people. So we've established a programme over the last quarter with our digital and analytics team to define some of those metrics that matter so that we can be really precise on the signals which tell us at either a particular service level or a particular portfolio or for a population group or a particular community within a population group on whether we are making progress to meeting their needs and making progress against the transformation programme that we've set out, including those 3 Darcy themes as well. So that is really, really critical work to us. We shared it with our all staff group at the end of December on an organisation-wide briefing call. And we are seeking to work with them to bring their intelligence into that as well, to ensure that we've really got some strong definition of all of that. So hopefully you can see how the 2 strands come together, both qualitatively through the engagement and the conversations with local people and partners, and then quantitatively through a data and analytics led approach. But it's critical for us to get that right.
Thank you very much, Sam. Let me bring Ilona in now. Thank you.
Thanks, Priya, and thanks, Sam, for the update. I just wanted to flag how good the session I attended before Christmas in Slough was. So I went along to, I think it was the final of the kind of system-wide sessions for partner organisations on the Reconnect, Reset, Rebuild engagement exercise. It was really well thought through. I think the ways in which they brought people into the conversation and made us do quite a lot of hard work to feed in thoughts. So I wanted to pass that on in this context and say a big thank you. And I know it's captured in your slide and your comments here, but it's really important that we build on that and let people know how we use the information that they've given us and the hard work and the time commitment they've given us, and let them know the kind of so what and how we're using that information going forward. But I know that's on your plan of next steps. And a practical thing, the more community focused events, I know you flagged a few specific ones that are already in diaries. Are they all being updated on the website? So if we want to tag along to some of those, they're all on the website with details, are they? So that's where we go. Okay, brilliant. Thank you.
Thanks, Ilona. Just to flag back to you, there are some colleagues who have joined the board this morning who are centrally involved in the planning and delivery of that work. So I know they'll be really pleased to hear the feedback from you directly, and we'll make sure that's disseminated into the broader team. So thank you for sharing that. And yes, details are being kept live on the website for future events. So you're very welcome to join us for any of those.
Thank you very much. And thank you to the whole team for all the work that's gone into that. I think many people have shared, Ilona, as you've said, how useful those sessions have been and how well run they've been as well. So thank you for that. Let's move then to our next session, which is our performance reporting for this current year. And we're going to have our 3 reports, our quality report, finance and performance, and workforce performance report. So we're starting, please, with Dr. Lily, our Chief Medical Officer, and then on to Richard Chapman, our Chief Finance Officer, who will cover finance, performance and workforce. Thank you very much, and over to you, Lalitha.
Thank you, Chair. At the outset, I just apologise. I have a bit of a tickle in my throat, so if I cough or need to reach for water, I just wanted to apologise at the outset. So next slide, please, Ollie. this just gives you an idea of what I'm about to cover in my slide presentation. Next slide. So just to say that the Frimley Integrated Care Board builds on and reflects the National Quality Board guidance on quality, risk response and escalation. And our presentation goes through the various aspects on which we are aiming to improve quality and provide safe, effective care. Next slide, please. So I wanted to start with an update on the vaccination program. The data that I share here is from the 3rd of January. And when we looked at the COVID vaccination program, which continues now right until the end of January, and in fact, there's a link on the slide where people can get their vaccine. Overall, our uptake has been around 47%. But if you look at the group in care homes and the elderly over 65, the uptake was much higher at 78 and 63% respectively. Similarly, with the flu vaccination program, which is on the right of the slide, which carries on until the 31st of March, although the average was about 53%, uptake in the care home residents and those over 65 was much higher at 82% and 75%. The respiratory virus, syncytial virus, RSV program, as it's known, started in September 2024, and about 51% of our population between the age of 75 and 79 have been vaccinated. Next slide, please. This is just the next few slides take you through the primary care transformation. So how is primary care looking after the residents that reach out to them? So newer ways in which we are helping cope with patients who are reaching out for various issues. So the first one is an app called the Get You Better app. This is about MSK, which is musculoskeletal problems. So we know that about 800,000 people visit the GPs each year for various issues. So you might have pulled a little muscle in your back and so on. And this is an app that has come together with work from our specialists locally, our orthopedicians who have come and worked with other physiotherapists and so on. And it's a national app, but modified to local needs as well. And 96% of our Frimley GP practices are actually providing this app. Over the last month, for example, 519 people have been given access to the app, and they have all registered on the app to get care when they need it. Now, you can see there that there are about 18,000 residents who have actually got access to the app, and we are finding that the reactivation of the app, the rate of it is actually going up, and we're monitoring it very closely. We are ensuring that every opportunity is taken up to empower our residents to uptake the app. Next slide, please. Now, this slide looks a bit complicated, but what it's trying to show is we hear a lot in the national press about what is called left shift or shift towards prevention and enabling self-care. And it's just a graphic representation that if a patient presents to primary care in what is called unscheduled care, so where they have come for a need on the day, could be that they have a chest infection or a urinary tract infection and so on, what primary care is doing, and Frimley is actually one of the early adopters of this principle, where we are looking after patients based on what is called risk stratification. So we know that someone can be generally well, and in them, for example, a chest infection is not as likely to get worse compared to, say, someone who has a respiratory lung disease as a long-term condition. So stratifying people and looking after them with the right clinician at primary care, looking after the patients who are more complex, and also then applying various apps using community pharmacy, where we know that there are now national programs where you have pharmacy first, where antibiotics, example, can be given for minor illnesses. So how do we use all our allied health professionals that are available within the community, working with primary care to make sure that our patients are well looked after? And again, the slide in the left talks about how do we keep people out of hospital if we can. So we have long-standing programs of work such as remote monitoring, where our residents stay well in the community, where they are enabled to look after themselves, but with teams that can actually go in and make sure the patient is well. Similarly, when they deteriorate a little, rather than going into the hospital in an unfamiliar environment, how can we keep people well in their own homes, how can we actually administer medications, perhaps even IV fluids within patients' own homes, so they then improve much better and go back to their normal lifestyle. So, and other than doing that, how do we then actually look after our patients when they are well? And so how do we schedule their care normally? And that is about when we look after people who may be diabetic or who have, say, blood pressure problems. How do we, again, look after those who are what we call in the red segment, or the more complex people, even before winter hits, for example, so that they stay well through winter? How do we enable they have all their vaccinations, they have all their medications optimized? Similarly, giving them access to various apps. For example, there's a fabulous app called Sleepio, and if any of you have not used it, I'd really highly encourage all of you to go on the app for Frimley. It's free access. And we have demonstrated that the use of medications such as sleeping tablets, for example, are lower in people who are using the Sleepio app. And again, if you take it one further step to what should be the left, although on the slide it moves to the right, is proactive care. How can we actually enable our residents and empower them to look after themselves and stay well? So if you are a hypertensive, do you actually know your numbers? What is normal for you? And when do you need to seek help? What is the importance of taking medications? And it's those kind of things. And of course, vaccinations, so that you stay well through and not get any illnesses through winter and other periods of stress. Next slide, please. So this is a public consultation that is actually that is beginning with BHFT and ICB. Now, Berkshire Health Foundation is one of our providers of a community ward that is actually located currently in Slough in Upton Hospital. And there is a proposal to move the ward to St. Mark's, where there is another ward, and it is envisaged that this will actually improve the quality of care and experience. And it's scheduled to begin in spring 2026. And there's a public consultation that our ICB comms teams are working with, along with the Berkshire Health Foundation, to make sure that we hear from our residents, hear their views. Next slide, please. This is about pharmacy and MedZops. Now, this is all about our MedZops team supporting our practices to make a delivery of improvement and make it as easy, as efficient as possible for our primary care colleagues. So I'll touch on a few examples. There are a lot of details on the slides. So it's about medicine safety. So for example, how do you make sure that the medicines we give have reduced complications, such as, say, bleeding from the gastrointestinal tract and so on? How do you make sure that you're not double prescribing medication? So if someone is already having a continuous glucose monitor, they really don't need a blood glucose testing strips. So it is those kind of things, looking into the computerized records, but making sure that we are being safe with medicines from primary care to our patients. Again, integration of community pharmacy and using pharmacy first. And there are a group of our patients who are quite complex, who are on multiple medications. So what is called polypharmacy. And how do we actually enable that people are on the right medication, that we reduce complications from one medication to the other? Things like antibiotic stewardship. So unless we do audits, we wouldn't know what are the areas of improvement. So auditing prescribing, for example, for urinary tract infection, making sure that the right antibiotic is being given, those kind of things. Next slide, please. Again, plenty of information on the slide. I'll just touch on one or two details. So medicine safety, I already touched on. And we are pleased to see, for example, that people who have low blood sugar or hypoglycemia, as the slide says, that prescription of medications that actually worsen low blood sugar, sulfonylureas, for example, are starting to decrease. Similarly, people who are at higher risk of bleeding, that they have a gastroprotective, the stomach protective medication, and those number of medications and how many patients who are not on it are now being given the protective medication. So it's those kind of audits that we're doing. Similarly, if you look at CQC, when we learn from CQC visits where there are areas of medicine management improvement, then our teams are actually going in to the practices, working alongside the quality team in order to enable better, safe care to be given to our patients. And not only that, we are aware that frontline staff do need updates regularly, effective communication. So our MedZops teams are reaching out to all the healthcare professionals once a month on whatever topic there may be. And of course, there may be ad hoc urgent topics, and all the frontline staff from various organizations, topics are picked up, prescribing, dispensing, and administration conversations happen. We're also working with external partners like the Health Innovation Oxford and scoping different pilots. For example, how do we look after our patients in a holistic manner? Or those living with chronic pain, for example, how do we pilot a biosocial-psychological model? Next slide, please. This is again from our pharmacy workforce transformation. Now, we were successful in a bid for the local Frimley Teach and Treat program, which is a structured hands-on training program for a community pharmacist. We have had a record increase in our foundation trainee pharmacist places. We're also working on work experience programs with our partners like FHFT, having mentorship development. We are part of research collaborations with various universities such as Reading, University of Manchester, and so on. And our teams are actually presenting a lot of what we do at many conferences. And in fact, on the next slide, Ollie, next slide, please. Next slide, you will see two of our staff members who led a system-wide care home project on the use of thickeners, which thicken the fluid and therefore reduce the risk of, say, fluid going into the lung in somebody who is really elderly. Their work was recognized nationally and they recently won an award. Similarly, on the right, you'll see Yinka, who is one of our community pharmacy leads, talking about her achievement with the ICS Pharmacy First program. So plenty going on and plenty of recognition for this team who's doing a great deal of work. Next slide, please. So this is next slide again. This is about CQC updates. So Ringmead Medical Centre, one of our practices in Bracknell, the doctors, nurses, and the team continue to make improvements, listening to their local population. In fact, on the 10th of December, we had our own chief nurse supporting the event, working alongside with the practice and local counsellors, discussing all the improvements. We are aware that CQC have carried out 2 additional primary care assessments in the Frimley area. Nothing of concern was flagged to the practice during the feedback session. And as usual, once we review all the assessments, any identified learning will not only be addressed at the practice, but also shared system-wide. And I think my next slide is the last slide, which gives you a general overview of our various providers, and the majority of our providers remain at the point of being good. Next slide, please. I think that's my last slide. I'd stop there, Chair, and should I pass on to Rich or take questions? How do you want to do this?
Let's pass on to Rich, I think, and let's have the next sessions. Thank you very much, Lalitha. That was so interesting and such a lot of ground covered there. Let's pass on to Rich and pick up on finance, performance and workforce, and then we'll ask our board for comments and questions. Thank you.
Thank you, Chair. So I'm going to run through the finance position very briefly. We discussed it in detail at Finance and Performance Committee and in the private board. The published papers are at month 7. They indicated a £600,000 deficit for the system against a planned surplus of 2.4 million at that point in time. The month 8 assessment was that a most likely outturn for the system will be a £2 million deficit, with work ongoing to mitigate that gap. We are, at the time of speaking, still expecting to break even, but that position is far from being without risk, and it remains reliant upon a step change in efficiency delivery through the remaining months of the year and our continued grip on expenditure control. In terms of performance, I'm going to cover urgent, emergency and planned care first. Again, paper's a little bit out of date, so what I'm going to bring is the most recent data that we have, which is that the January month to date 4-hour wait performance is at 75.7%. That is third out of 17 acute providers in the region, and it's in the top quartile nationally. We're making good progress towards achieving the 78% target in March, and that position is 1.6% ahead of the plan for the month to date in January. For ambulance,
Rich, can I just hold you there? Are we? Was it the intention that we'd have a slide on screen at the moment?
No, I haven't got this on the slide yet because it's the most recent data that we have available.
Thank you.
So ambulance handover time, now we're currently ahead of target, so we're averaging 29 minutes 47 seconds against the 30-minute target, and all this I think is reflective of a huge effort in the discharge space, which is freeing up acute beds. So across all of our sites, patients with no criteria to reside, the numbers are regularly dipping below 200, and 14-day plus occupancy is down to 10.4% of the bed base. Planned care recovery is strong. We have during January received the news that 78-week waits have been eliminated in the friendly system, although the size of the underlying waiting list remains a concern. And also in planned care, cancer performance continues to benchmark well, but we are having challenges in the area of dermatology. I've been asked to mention, Chair, particularly the level of support we have received from system partners with discharges. So through the pre-Christmas period, across Christmas and New Year, and on an ongoing basis, we have increased our discharge levels by more than 50% above 2022 levels overall. And in particular, post-Christmas, the most complex discharges, the pathway 1 to pathway 3, we have delivered a 48% year-on-year increase in discharges, which is freeing up beds, which is what is enabling that ED and planned care performance. So thanks to system partners, in particular local authorities and other agencies working alongside FHFT and the provider organisations to facilitate that. In primary care, so the digital offer from our primary care providers continues to facilitate really good timeliness in appointments. It's better than last year. It's amongst the best in the country. And 83% of our September appointments were fulfilled within 24 hours and 90% within 14 days. The fact that that is a digital offer means that we are below the England national average on face-to-face, and it's almost kind of a trade-off between timeliness of access and face-to-face, but we believe that we are performing effectively in that area. In mental health, so we have currently 25 inappropriate out of area placements. Sorry, did I say currently? That's at the end of September. Latest data that I have available. There is a case through the System Resourcing Group this week to support Hampshire, in particular, where the length of stay for Hampshire is materially higher than it is for Surrey. And the objective there is to reduce the length of stay, to free up beds, to reduce the number of inappropriate out of area placements. In terms of workforce, the temporary staffing collaborative is led by Friendly for the whole of the South East. It's helped to deliver a year-to-date £85.2 million reduction in spend year on year, which is 10.5% of our temporary staffing spend. And the agency spend represents 2.9% of the pay bill in the year-to-date, which owes a lot to a really strong commitment from providers to framework rates, and we are utilising BI tools and obviously local and system level controls to help to drive that efficient delivery of care. And finally, all three providers' absence rates are below the regional average. I'm going to pause there, Chair, and I'm happy to take any questions on that.
Thank you very much, both Lalitha and Rich. That's been very helpful. We've now heard about quality, performance, finance and workforce. And thank you to all committee chairs and members of the committees who have been considering these in some detail over these past weeks. Can I open up now to comments and questions, please? Fiona.
Yeah, I just wanted to expand on Rich's point about system partnership around the emergency pathway, just so that everyone can understand that the level of collaboration between ourselves and our 6 main first tier authorities, so that's Bucks, Slough, the Royal Borough of Windsor and Maidenhead, Bracknell Forest, Hampshire and Surrey County Councils, on that we have a joint discharge data platform in terms of a dashboard. So everyone works to a common data set and joint ownership. And then we have started to mobilise just before Christmas a multi-agency discharge event, and then last week a multi-agency discharge event. And those, in the old days, those events were really difficult to organise and mobilise, but now it's becoming automatic for people to come together and drive the improvement. And I think we had the highest level of discharges collectively last week that we've had since we've started our whole system urgent pathway work. So I just wanted to factually bring it to life, the scale of that join up between health and social care.
Thank you very much, Fiona. And the impact for patients and their carers and families is enormous in getting that right. Grania, come in.
Yes, just to supplement the comment made by Fiona, I think we're still the only ICS system, aren't we, in the country that has the joined up data, and it has been a big commitment, but it means we can operate so much more efficiently and effectively for our local residents. So in terms of the ability it gives us then to tailor the improvement programmes for us individually and then collectively to work on in terms of the discharge process, I don't think that can be understated. So it is a wonderful achievement for us to have made, and we're seeing improvements with it all the time. So I thought I'd supplement that as I am involved.
Thank you very much, and thanks to all system partners across all sectors for making that work. Let's move now then to our board assurance framework, and back to you, Richard. Thank you.
Jay, you surprised me. I've got to get off mute again. Thank you. So the board assurance framework is presented in the papers. It describes 6 strategic objectives which are detailed in the paper, with risks and mitigating actions which are regularly reviewed and updated. The board has established its risk appetite for each strategic risk as described in the paper, and the assurance framework compares the current risk against that risk appetite so the board can see which objectives are running within and which are without that established appetite. You'll see from the papers that the risks to the achievement of 3 strategic objectives are currently sitting outside of our risk appetite. Those objectives being starting well, living well, and outstanding use of resource. And for places, people and communities, our people and leadership culture, the risk assessment says that we are sitting within the board's established risk appetite. The papers include the specific measurables for each objective's risk assessment, for the positive assurance and controls in place, the gaps in assurance or controls, and the actions which are in train to address those gaps. I'm going to assume that everybody has read the paper, Chair, and I'm happy to take any questions at the content.
Thank you very much, Rich. And can I open up, please, for any comments and questions? Ilona, thank you.
Hi, thanks, and thanks, Rich, for the overview on the BAF. I just had one question. It was good to see the positive movement on strategic objective 2, which is the kind of, I think it's the living well one. Sorry, my laptop just crashed, so I had it all open and now it's closed. Reading through the detail, it was a little bit tricky to understand what's changed, what's kind of materially shifted since this was last reviewed to drive that improvement? I know there's lots of good activity, but actually, from my perspective, this is still something we're pretty concerned about, especially as we go into a tight planning round next year. So I just wanted to understand what driven the shift in score. Thank you.
Any other questions? Or take that one. Okie dokes. So the change in the living well risk assessment is in the likelihood that the risk will materialise. The living well risk is described as if we are unable effectively to implement and integrate the whole system strategy that supports the transformation of care to asset hospital settings, then the anticipated reduction in hospital activity may not be achieved. This may exacerbate health inequalities, leading to increased pressure on partner organisations, higher healthcare costs with risk to our recurrent financial sustainability and poorer access outcomes and experience for local communities. And trying to assess what so it's Letha that owns the risk, and trying to assess what changed in terms of the likelihood. But I think it will be the bringing together of the planning process and the strategic approach to a 5 and 10 year plan for the system that we have been discussing elsewhere in the system. I can see though that Sam has his hand up, so I'm going to shut up.
Yeah, thank you very much, Rich. Letha and Sam, do please come in.
Yeah, really happy to, and Letha, please add. So a couple of points on the movement, Ilona, from the previous version of the BAF that you will have seen. Firstly, as chief officers, we meet monthly to review this, and just to test that the relative scores between the different elements of the BAF feel sensible still. Certainly when we looked at this one again last month, we thought that we'd perhaps been a touch too bearish on this and adjusted it accordingly. More importantly is a review of the mitigating actions that we've got in place around trying to avoid the crystallization of some of those risks, most notably some of the work that we're doing around tobacco cessation and the work with partners on achieving the tobacco cessation standards, particularly for maternity and inpatient-based patients, ensuring that they receive timely access to tobacco cessation support and nicotine replacement products. We have now got a new set of mitigating actions in place between the ICB and its partners, particularly its partner at FHFT, around how we ensure that the risks to delivery of that programme are going to be covered off. And we felt that given that we had a clear way forward on that, it was appropriate to adjust the likelihood of the risk crystallizing down slightly, which you've seen in that 1 point drop since the previous version of the BAF. I hope that helps answer the question.
Thank you very much. Lily, did you want to add?
Yeah, thank you. And I guess, thank you, Sam. And the other things to add there is that, of course, fairer funding has kicked in from the 1st of July, which we know from evidence in LLR, for example, gives better access to primary care for our patients. Almost all our practices are using segmentation, as I said earlier as well. And we know that our programs such as remote monitoring, virtual wards, keeping people out of hospital, which was the original risk that Rich read out, we have had external evaluation on the methodology that we've used to evaluate our work along these, and the evidence that we found of reduced GP contacts, reduced 111, 999, and ED attendances, admissions, and all of that. I think everything played into our conversation that we have as chiefs monthly, and that's why that all contributed to a reduction in the number.
Thank you. That's really helpful. I mean, just a suggestion, I think capturing some of that conversation in the cover note would have been really helpful. So if in future where there are material shifts, which we hope to see, we don't want it to be static, we want to see it changing, and, you know, where we become more worried, less worried, etc. But capturing some of that would be really helpful. Thank you.
Thank you very much, everybody. Let's move then to our next session. So we, as I mentioned, we have one question from the public in relation to long COVID, and we'll be giving a written answer to that. So thank you. It's very helpful to have these questions. There's also a query that came in after the close of our time for questions around artificial intelligence. And again, we'll be directing that question from a supplier to an appropriate member of the team. May I then ask from board members, is there any other business? I'm just looking around my screen and I'm not seeing any hands. Thank you very much, everybody, for joining today. Thank you to the board, to all of our system partners and members of the public who have joined. And thank you also to the team that have made it possible to have today's meeting. Thank you all.
Thanks,
Bye-bye.
Priya.
Thanks,
Bye all.
Thank you.